Diyeyim. Ondan. Tamam. Good afternoon, everyone. Today, we are lucky to host Sila Kurugol, who is an assistant professor at radiology department at Harvard Medical School and the director of the Quantitative Intelligent Imaging Research Group and the PI at Computational Radiology Lab at Boston Children's Hospital. So a little bit about her background. She received her PhD degree in electrical and computer engineering at Northeastern University, and her research mainly focused on development of innovative algorithms for MR image acquisition, image analysis, and image interpretation, especially in the areas of image reconstruction from accelerated acquisitions and motion-compensated imaging. And today she will talk about their efforts on applying deep learning for quantifying clinically useful information from both 3D and 4D MR images. Thank you, Sıla. The stage is yours.
Thank you so much for the introduction, and it's so exciting to be giving a talk today in this excellent, really exciting seminar series. So I'm going to be talking about mostly medical imaging and image analysis. So just to introduce myself a little bit, my name is Sila Kurugol, and I graduated from Middle East Technical University and then went to BCAN for a master's, and it was all in electrical engineering. And then I came to Boston in 2005, and then I did my PhD here and then postdoc, and I started as a faculty member in Harvard, one of the hospitals of Harvard Medical School, Boston Children's Hospital, which I currently work at 2016. And now I have, I'm working basically, I'm a faculty, I do not teach, but it's fully research. So we are working with radiologists and clinical people in the hospital, and we are trying to solve basically clinically important problems that they bring us and then ask us to work together. So, and our main goal, and I'm going to focus on some of the topics that we have been working on in the last couple of years, and our main goal in this is to really generate some clinically useful quantitative information from 3D or 4D magnetic resonance images. And today I'm going to focus on three areas. One is accelerated MR imaging and how can we reconstruct good quality images from data when we don't have the fully acquired images, which are when we have limited measurements. So how can we do image reconstruction? And the goal is to make MRI faster. And the second topic that I'm going to talk about is motion, which is especially a big topic in imaging children with magnetic resonance imaging, because they often move and they may need sedation, which we would like to avoid as much as possible. And if there is motion when happening during acquisition of MRI imaging, we have lots of problems. We have signal degradation, images are corrupted, we may need to reacquire, and in some situations that may not be possible. So motion is a big problem. And there is also the motion happening due to respiration or cardiac motion. There are other inherent motion reasons of motion happening. And the third topic I'm going to talk about is quantitative parameter estimation from MRI. So there are multiple contrast mechanisms that we can generate with MRI. And this includes diffusion weighted MRI, perfusion weighted MRI. And what we do is we get measurements over time or over different parameters, and we try to fit a quantitative model and estimate these parameters. And these parameters are usually either descriptors of perfusion or microstructure of the tissue. For example, how much cellularity there is. In cancer, we have more cellularity, and normal tissue, we have less. So the idea is to get some quantitative parameters that we can use in clinical practice to make clinical decisions. And we are very lucky in our environment because when we solve these problems, they are directly applicable in clinical practice and can be used immediately to solve and to make clinical decisions and solve these problems. So this is like a really exciting field to be in. So I'm going to just start with a brief introduction of magnetic resonance imaging. So this is a really cute scanner we just got installed in our new building. So this, because we are at Boston Children's, we always have a cute theme in the MRI room. This is like an aquarium theme, I guess. So we prefer MRI over CT or other cross-sectional imaging techniques because, first of all, it has no ionizing radiation, which is potentially harmful. It may even lead to cancer. And MRI only uses radio frequency waves and a very powerful magnet that you place the patient into, and you excite the tissue and you generate images. So, and we can generate, there are so many different mechanisms that we can generate contrast. We can do the basic T1 weighted imaging, T2 weighted imaging, or we can do T1 mapping, T2 mapping, which you actually acquire multiple T1 weightings and then fit a model to estimate T1 relaxation rates. And then you can do perfusion imaging to look at perfusion rate, flow. You can do diffusion imaging to look at tissue microstructure. As I talked about, you can look at whether the tissue has more cells, so it restricts the diffusion, like in cancer, or you have more free environment, like free diffusion is more possible. So we can do many things with MRI, but MRI is very slow because when we acquire the data, we acquire the data from case space where we sample each line, and then this takes very long time to get to acquire the measurements in frequency domain line by line. And then if we take the inverse Fourier transform, we can reconstruct the image. And we really would like, one of the things we would like to do in MRI research is we would like to make it faster and reduce the acquisition time. And how can we do that? Like, first, we can acquire less number of phase encode, less number of lines, right? For example, if we reduce the number of acquired lines by 2, we can do 2 times faster imaging, but it results in aliasing artifacts. And because of the NICU sampling rate, right? NICU sampling rate tells us the sampling rate should be at least twice as high as the highest frequency in the signal. And if we do less, and it results in these kind of aliasing artifacts. And then we would like to resolve these artifacts. So one of the methods to do that is parallel imaging. And parallel imaging is based on taking advantage of multiple measurements of the signal. We measure the signal, we put the patient in scanner, and we put a coil over the patient. And we have measurements from multiple coils. So, and as you see here, different coils are sensitive to different part of the image. So for example, this orange one is sensitive to this side, and then the yellow one has more signal from this side because the coil is closer to that side. So depending on the position of the coil, we have different sensitivities, and we generate a coil sensitivity map. And this map provides a level of spatial encoding, and this can be used to remove the aliasing issue with parallel imaging. So I'd like to talk about an example application that I have been working on. And this is dynamic contrast enhanced MRI, where we don't just acquire 3D data, but we acquire 3D plus time after injection of a contrast agent. And this contrast agent is gadolinium, which basically shortens the T1 of the signal and generates these brightness while the contrast flows through the tissue. So what we do with this is we would like to measure it very fast. So we would like to acquire 3D data 3 seconds per volume. So this will require very fast imaging. The reason for that is that because the dynamics of the contrast is very fast, and it goes through aorta into kidneys and then filtered through the kidneys and goes into the collecting system. And to be able to capture this fast dynamics, we would like to do accelerated imaging. And also, we would like to measure the contrast concentration and model it with a tracer-kinetic model and estimate parameters such as, for example, the flow rate from aorta to renal cortex gives us a measure of perfusion of kidneys, and flow from cortex and medulla gives us a filtration rate of the kidneys. So those are important markers that are used for making clinical decisions. For example, the filtration rate that we provide to the urologists is immediately used to make a decision whether the baby will have surgery or not, whether the kidney function is declining, and if it keeps declining, this may lead to chronic kidney disease and chronic renal failure. So they would like to look at the markers of kidney function and operate if the function is declined. So for dynamic contrast and enhanced MRI, as I said, our wish list includes accelerated imaging to acquire each volume very fast. And then we would like to do, of course, we will have to undersample the image. We cannot require the full data. We will have to acquire only part of the data with undersampling. And then we will use some sort of compressed sensing technique, integrating some prior information to be able to reconstruct the images from this limited amount of acquired data. And using the temporal information, we have additional information over time, because there is both sparsity in time and in image space. So compressed sensing theory relies on that. These three principles. First, we know that medical images are sparse, and we can apply transforms that will enforce sparsity, and we can use that as regularization. And also over time, this is even more true. And the second thing that we need for compressed sensing reconstruction is incoherent measurements. And an example of that is random sampling, but we can also use other different non-Cartesian sampling techniques like radial sampling. And then the third part is to reconstruct the image using this regularization, using this prior information, using nonlinear reconstruction, some iterative reconstruction technique. So first is, as I said, is sparsity. So as we know, for example, from this famous Shep-Logan phantom image, we know images are piecewise smooth. At least this is the assumption. And sparsity means if we transform this image into a transform domain, for example, if you take the edge map, the transform will be the edge detector, then the signal becomes sparse in this domain. So we assume if we transform the image into some domain, for example, wavelet domain or some domain, then the image becomes sparse, and we can use some sort of regularizer that enforces sparsity as a prior. And in time, in dynamic contrast enhanced MRI, for example, we have even additional sparsity, which we can take advantage of. The signaling time is more sparse, and we can, if we, for example, apply a transform, like just get like the derivative in time, finite difference, the most pixels will be 0, so it will be sparse. And second component is incoherent measurements, as I said. So it could be, we could use random sampling, or we could use some sort of non-Cartesian sampling schemes. And one of these sampling schemes is this golden angle radial sampling. This trajectory is very interesting, and we have been using it quite a lot because it both gives us a very incoherent measurement like random sampling, which is great for compressed sensing, but also the undersampling artifacts are in terms of streaking artifacts, which can be reduced by regularization. And also it is the advantage of this kind of sampling scheme because it always samples the center of K-space, which is where the low frequency information is. We would like to always get the low frequency information so that, excuse me, we can always get this low frequency information, which gives us motion robustness as well, which I'm going to talk about later. And as I said, the third component is compressed sensing reconstruction. So this is the image reconstruction problem that we are solving. So given limited number of some measurements that we did from the K-space, we can solve this physics-based problem. So we are trying to reconstruct the image. Normally we just do it with inverse Fourier transform, but because we have a specific sampling scheme, we need to use non-uniform FFT. And we have this coil sensitivity maps that we can take advantage of for parallel imaging. And we would like to reconstruct this image D from K-space measurements M. But because we are undersampling, we would like to add a regularization, and this regularization is in terms of a sparsity enforcing regularization. We transform the temporal signal into a sparse domain, and then we used one norm for sparsity enforcing regularization. And this compressed sensing reconstruction has been shown to achieve both, like compared to Cartesian sampling, which can only do a temporal resolution of 11 seconds. With this kind of golden angle radial sampling scheme, and with the compressed sensing reconstruction, we can actually reconstruct pretty good image quality with very high temporal resolution, which is around 3 seconds per volume. And we eliminate the streaking artifacts, which are due to undersampling. Like in radial acquisition, instead of the aliasing artifacts that we see in Cartesian sampling, we here in the radial see the streaking artifacts due to undersampling. And we remove them in the compressed sensing reconstruction. But the problem with compressed sensing reconstruction is that we have this regularization term that we would like to optimize this term. And of course, there's a trade-off between low and high regularization. If we use very low regularization, there is still lots of artifacts remaining in the image. But if we use, due to undersampling, if we use high regularization, then the image is over-smoothed, especially the temporal component of the image. And we don't want that because we use that temporal signal to estimate, to fit a model, quantitative model, and estimate its parameters, like, as I talked about, like filtration rate or perfusion. So we don't want to over-smooth the temporal component by increasing the regularization too much. So that's why we thought we could solve this problem more smartly and maybe not use a prior and the regularization term here, and instead let the neural network decide how much regularization is needed. Therefore, as you see here, if we use very low regularization, there is a lot of remaining noise and streaking artifacts in the background and in the signal from aorta here. And if you do very high regularization, we over-smooth the temporal signal. And this basically completely destroys our estimations of the flow rate and filtration rate. So that's why there is a trade-off. And here you see in image quality-wise, when we use low regularization, we have pretty much noisy and poor quality image reconstruction of the kidneys that are shown here. And if we do high regularization, image quality is improved, but then the temporal signal is over-smoothed. So that's why we, in one of the recent work we did, we used the idea from the deep image prior paper. And deep image prior is using basically the idea that the images are lying on a lower dimensional manifold, lower dimensional structure. And the network is trying to start from a low dimensional input Z, which is a noise, which is noise here. And then they try to reconstruct the image by iteratively. At every iteration, it goes through the network, and network kind of plays the role of a regularizer. And then without actually including a regularization term, just by promoting fidelity between a deteriorated observation that we measure and our image that we would like to reconstruct without deterioration. For example, we have a noisy image and we would like to reconstruct a denoised image, or would like to do in-painting, or we have an image with artifacts and we would like to have an artifact-free image. So that's the measurement is the artifact image, and we have the image regularized from the network, and we do this multiple iterations. If we continue doing these iterations, it will eventually overfit. What if we stop it at an earlier time, then the network plays the role of a regularizer and remove noise, only keeps the low dimensional structure, which is inherent in the images, and removes the unnecessary artifacts. And this has been shown to work well in multiple applications. For example, from a compressed JPEG image, they could get the reconstructed image with fine details. And we apply this for image reconstruction in MRI, in dynamic MRI. So for reconstructing one image, you can just start from a lower dimensional vector Z. And this is, M is much lower than N squared, which is the size of the image that we like to reconstruct. And then you pass it through this network, and you try to solve this problem, which is you have your regularizer network. This is our data consistency term. And then we have our measurements, which are noisy measurements. So we would like to reconstruct this signal, which is the output of the network, a regularized version, which doesn't have artifacts due to undersampling. And for each volume, this can be done over time. But because we wanted to also include information a long time, we designed this Z vector in time. So we didn't just use a random Z, but we added we designed a Z input that also takes into account the correlations in the data over time in our dynamic contrast enhanced MRI. And to do that, we basically did something very simple. We just got our case-space measurements. We just use inverse Fourier transform, non-uniform Fourier transform to reconstruct them. But we got without any regularization. The images look pretty noisy and has a lot of artifacts. And we use these images in time to basically divide the temporal signal into phases. And these phases are incorporated in our design of our lower dimensional input. So it's temporally correlated. Starts from a random input, and it basically generates these vectors. And the only constraint is that these vectors will be piecewise smooth, and each piece is coming from our phases that we have generated from our temporal curves from the noise reconstruction. And then we apply this deep image prior method for dynamic image reconstruction using these kind of structure. We start from case-space measurements, and then we get our this lower dimensional input. It passes through this network, and then it reconstructs an image. So this part is just some fully connected layers to generate a larger dimension, and then we use some convolution layers for basically removing the artifacts. And then at the end, when we look at the results of the reconstructed images, they are pretty good quality, close to the quality of highly regularized reconstruction when we use the high regularization sparsity prior. But also the best thing about it is the temporally, it doesn't over smooth. So temporally, it is close. The temporal signals that we get, the green ones from the deep image prior reconstruction, is close to the lower regularization reconstruction. But it has less noise, and it doesn't over smooth the temporal signal. So we could achieve the advantage of both spatial regularization and also without temporal smoothing. So this temporal smoothing is really bad for our purpose, because if we over smooth the signal in time, we cannot estimate the quantitative parameters with good accuracy. So, and here are some videos of the dynamic signal showing the deep image prior reconstruction and some compressed sensing reconstructions with increasing regularization. With largest regularization, we have the best image quality. We get rid of these streaking artifacts and noise. But again, as I said, the temporal signal is over smoothed. But here we have both good image quality and without over smoothing the temporal signal. So as I said, compressed sensing approaches can be used for image reconstruction from undersampled data. And here we use the deep image prior method, which is completely, doesn't require any training data. It's completely self-supervised and single subject based optimization. So it also has the advantage of not needing homogeneous training data or a training data that can capture different kind of possible subjects for future generalization purposes. And it could improve both the image quality and temporal without losing the temporal features of the signal. So this is the first part of my talk. I don't know if I should continue or let people ask questions.
If you wish, we can take some questions. So actually, I have one question. So in this work, did you also introduce some additional temporal coherency losses over these latent vectors, or?
So the only temporal thing we did, which we actually wanted to really include, because normally you could reconstruct each image independently, right? You could just take a lower dimensional vector, which is random noise, basically, and then you reconstruct the image and you have the measurements and a regularized image from the network. But we also wanted to include some temporal information, right? Because these images are temporally correlated. So that's why we designed this inputs, these, in a piecewise continuous manner, and each piece is we call it a phase in time. So these phases are generated from the original data that's very noisy reconstruction by just applying a Fourier transform, non-uniform Fourier transform. So these noise images are used, and we apply PCA, and then we apply some sort of clustering in time. And we got these phases, and then these phases are just imposed when designing this random vectors. They are still random, but they are piecewise continuous. So this included the temporal correlation into the reconstruction.
Yeah,
but I think there are many other ways we could take advantage of the temporal signal. And but this was the easiest thing to try. So we did this, and it worked well. So we didn't try more advanced things yet. Thank you.
Oh, okay. Can I have a question?
Sure.
Yeah, sure.
Hi. Nice to meet you, by the way. I'm from Boğaziçi University. We haven't met before, but I'm working on medical imaging and in different subdomains. So my question about the compressed image reconstruction, which I am not working on the image reconstruction part of MR, mostly on the analysis part actually, but the trajectories in the case space, either radial sampling, random sampling, or spherical sampling, which actually has a higher concentration at around the DC component. In any case, those trajectories are also noisy. I mean, you may not be actually acquiring the data at the special frequency that you think you are acquiring the data, in which case, actually, there needs to be some regularization or some trajectory learning or some trajectory correction in that problem. So is it also involved in the compressed sensing reconstruction scheme that you have defined a couple of slides ago?
Yeah, it's very true. Now one of the popular things people do is trajectory optimization. They try to design a trajectory that's optimal for undersampling and compressed sensing, as you said. But when I ask it to my colleagues, MR physicists, that's exactly what they say. Trajectories are not ideal. MRI hardware is not ideal. So we apply these gradients to generate those frequency and phase encoding, right? But they are not ideal. Yeah. So there is always measurement errors, and we try to measure it and correct for it at least as much as we can. For example, the radial acquisition scheme, it's supposed to be passing through the central case space, right? And that's the advantageous thing about radial sampling, because every time every line acquires this central case space.
Yeah.
And includes the low frequency information, but actually it doesn't. There is some gradient imperfection that causes it to be shepherded. So we correct for that, but it's not perfect. That's why it also gives us, it also has some advantages, but disadvantages as well. One is like it generates some randomness of the measurements and incoherent artifacts along time. So those incoherent artifacts, like undersampling artifacts, generate some sort of better opportunity for regularization because they appear randomly in different places over time. But you are completely right, and we cannot just come up with like crazy trajectories for case-based sampling because they may not be realistic at all. Even if it's like simple as radials, there is imperfections, and we correct for some of it, but there is definitely remaining imperfections which cause problems. And another problem, for example, which we are tackling is some coils gives us, for example, pretty bad measurements, and we have to really remove those bad coils. So we have actually an algorithm before reconstruction which selects the good coils. So there are many other things going on to be able to generate a good quality image.
Oh, okay. Thank you. Actually, a small side question, which may actually overlap with your second part of your talk about, can these trajectory impurities or errors in the trajectory be seen as like a motion artifact, actually? I mean, can we tackle with these trajectory problems or regularization problem as if it's a motion problem, basically?
I think that's what the motion also does, right? So motion also basically places the k-space lines into places where we don't want them to be, because we are trying to put them back into the correct places, right? That's what we do with motion correction, and I think that has the same effect. So I think you're right. So it could be thought about, but I guess the effect is very maybe less subtle depending on how much motion you have. So, but I'm going to talk about that. Maybe we can discuss more after.
Sure. Sure. Thanks.
Thank you for great questions. So maybe if there is no other question, I will start the second part. So the second part will be related to motion problem in MRI. And as I said, MRI is very sensitive to motion because it's a long process. We acquire each line, and motion happens between acquisitions. It can happen between one k-space line to the next, or it can happen from one slice to the next, depending on the different acquisition schemes we use. For example, sometimes we acquire one 2D slice very fast, but there is motion from slice to slice, and we try to solve it by techniques like slice to volume registration. Or sometimes, like in this case, I'm going to talk about in dynamic contrast and SMRI, it happens every single line can be corrected because there is that's the advantage of the acquisition scheme. So what happens when there is motion? So the motion can be because of the children move during imaging, even if we ask them not to, and sometimes we have to sedate the children at a certain age to be able to image them in MRI, and sedation has some side effects and we would like to avoid it. So we have programs in our hospital like Try Without programs, which is trying to image the children without sedation. And for babies, we are trying to put them to sleep and then image them without sedation. We image babies like a couple weeks old or a month old and hope that they sleep through the imaging, but sometimes they even move during their sleep. And as a result of motion happening during acquisition, there are two effects. One is if the motion is happening during acquisition of a line, it degrades the signal and image quality is degraded. In Cartesian imaging, we have these ghosting artifacts due to motion. In radial, we see different artifacts like signal degradation. And if the other effect that motion has is the misalignment between volumes. So what does motion do? So if we acquire these lines, these k-space line by line, if there is motion happening, then it breaks the assumptions of our acquisition scheme. So normally we encode each line and then we apply gradients to do spatial encoding, and we also do frequency encoding to be able to resolve these locations of the line, the acquisition sampling in k-space. And if motion happens at critical times, it will, as I said, break the assumptions, and it can lead to displacement of these lines acquired. It can lead to these Nyquist sampling violation because we didn't sample enough, there's a gap. There may be phase shifts in this phase encoding dimension. There may be ghosting artifacts, blurring, and degradation of image quality. And I'm going to specifically focus on the application of dynamic contrast enhanced MRI here to show the effect of motion. So it could be due to heavy breathing because the child is nervous during imaging, or it could be because the babies either woke up or moving during sleep, which you see there's a lot of degraded image quality and you see the motion. So for dynamic contrast enhanced MRI, when there is motion happening, as I said, there are two effects. One is in time curves, you see over time, the signal degrades at some point when the baby is moving. When you acquire during motion, the baby will be moving. And if you acquire, maybe if the baby change position from this position to this position, then there is misalignment also between volumes. So as you see here, the segmentation overlay after motion is misaligned. And these are the two effects of motion we are trying to correct for. And of course, there is different kinds or different frequency of motion happening. It could be happening intermittently, which we could correct for, and we could detect motion events as outliers, or it could be happening all the time, which in this case, you have to reacquire the data if possible. But if you have this kind of dynamic contrast enhanced MRI, you cannot really re-inject the contrast. So you have one shot basically, and you are trying to do recovery from very corrupted data. Excuse me. And this is the compressed sensing reconstruction without dealing with motion. Basically, you combine these radial lines and you reconstruct each volume. And then you apply this data consistency and regularization, enforcing sparsity in time. But sometimes you get these pretty bad quality images because motion happened during acquisition. So how do we detect for motion? First, we use this coil information, right? We measure different signals from different coils, and we assume if there is motion, each coil will start to see a different signal because the patient moved, and the coil measured by each coil will be signal measured by each coil will be different. So we can look at inner product between the vectors, for example, or we can actually model the time intensity curves and then look for outliers. So in our first attempt to detect this, we just looked for a motion outlier detection metric, and we just looked at the K-space center that you see here in red. K-space center measured at multiple coils. And we generated basically a motion measure, which looks at within a window the correlation between the signals measured from different coils. And then if this is larger than a threshold, we detect as motion or outlier. And then the first thing we did was basically removing those volumes affected by motion, which then we could recover if there is enough remaining K-space line after removing the bad ones. If there is enough measurements left for that volume, and we also do regularization, so that also could recover, and we could reconstruct images still with good quality. So for example, this is the first line here shows the image with motion, acquired during motion with very poor image quality and SNR. And we just removing the bad K-space lines and regularizing over them, we could improve the image quality a little bit. Again, another example where there is a loss of image quality, signal degradation due to motion. And here, with just outlier detection and removal and regularization, we could generate a little bit better looking images. And now we are looking at other techniques. During reconstruction, we would like to also incorporate take into account the misalignment between volumes before and after motion events. So this is our forward model where we have the image that we would like to reconstruct, unknown image. These are the measurements from K-space, and those are, in our case, radial sampling. It could be Cartesian sampling as well. So this is undersampled measurements. And this is our system matrix, which includes normally just Fourier transform and coil sensitivities, but here we include the motion here to align each image to a reference image. So then we could measure this motion for each volume. This is also unknown, that will be estimated, while also reconstructing the image, unknown image X. And this can be done iteratively as with gradient descent. First one is just our classical image reconstruction, assuming M is known. And then we solve for M, which is the motion estimation for each time point. And we do this iteratively until convergence, hopefully. And then we also, for outlier detection, in this case, we use the Gaussian process by fitting the Gaussian process model to the mean, to the signal from multiple coils. And then we detected outliers and divided the temporal signal into phases. So these phases both correspond to different contrast levels, like different appearances of image along time, but also they correspond to motion. So some of these are, the outliers are detected by this method. And the nice thing about this method was when we divided data into phases by clustering the Gaussian process mean, we could register and solve for misalignments only between phases instead of trying to register every single time point to a reference, which reduced the computational speed, because then we could also generate use more data to generate image from each phase, and then use that to align images from different phases. This could be phases due to motion or phases due to different contrast levels, contrast flowing through the kidneys. And here there is an example from a volunteer doing heavy breathing, and we acquired images and we looked at how we detect the motion, respiratory motion, using this technique. Our correlation-based technique didn't work in this case because it detected everything as outlier, but with using the Gaussian process mean, we could separate it into inspiration and expiration phases and reconstruct the images into different phases. So the other thing we did, as I said, the first step was outlier detection and removal, but there is also misalignment between volumes due to motion. If the patient moves from left to right, and the images will need to be registered to each other to correct for that misalignment. And for that, we did registration, but registration has some issues in these images because the contrast changes over time. The images do not really look similar. So to solve that, we came up with a model-based registration technique, and we used a very simple linear time invariant model that we fitted to the time intensity curves, like dynamic signal over time. And then we generate these templates, which are motion-free. And then we use these templates as a reference. Instead of registering each volume to a reference image, which looks different over time, we register them to the corresponding contrast image generated from the linear time invariant model. And for that, we use this very simple LTI model. And basically, given this motion data with motion in blue, and these green areas are the parts that are detected as outliers, the motion events, which we remove. And there is misalignment here. That's why there is a jump in the signal. So, we fitted a template LTI model, and that looks smooth and motion-free. And we use that to register each image to the corresponding template image to generate aligned volumes. And this is how we did the registration, basically. And here are some results showing the line image over time. Here we took this column and plotted over time, and you see a lot of misalignments in the original image. And if you register to a reference image, we solve some of it, but when we register to its corresponding template image, we get some slightly improved results in the registration process. And here also we show another example, a baby with some motion happening. And during these motion events, there was misalignment, which could be partially corrected with this motion corrected reconstruction and registration. Again, another example here. So if you look at the time intensity curves, In blue, we had the motion corrupted curve, and red was our model, Outlier model, and orange is the corrected curve after registration. So it could fix for the misalignments here. As I said, motion causes, in conclusion, two different problems in image reconstruction. One is when the motion happens during acquisition of a certain case baseline, it generates signal degradation. And if there is misalignment between volumes, we need to actually realign them. And this can be done either as a post-processing step, or it can be done during image reconstruction, and we can integrate the motion field, the deformation fields due to motion, and this is non-rigid motion, into the reconstruction process and solve for motion fields and the unknown image during reconstruction iteratively. And we did a model-based registration because there was too much contrast difference between images, and the registration approaches didn't work well. So by registering it to the corresponding contrast level, we could achieve a slightly improved performance. So I think this concludes the second part, and I'm gonna have, how much time do we have? Maybe finish up, and then, because we are running out of time, right? So just finish up and then we can take questions. So the third part will be about quantitative parameter estimation in MRI. So as I said, we have different mechanisms of contrast in MRI. So we measure signal at different either times or different T1 weightings or different echo times or different TRs, like different parameters, or in diffusion weighted imaging at different B values. So by getting the signal at different times, we have a model, a physics-based model that we fit to this multiple measurements, and we estimate the parameters. These are parameters that are representative of either tissue microstructure or perfusion. So these are very important clinically to make decisions, what kind of cancer the patient has, or whether the tumor is malignant or benign, for example. These kind of markers can tell us clinically important information. And in diffusion weighted MRI, we take advantage of the motion of water molecules in tissue, or in any, like if you take a cup of water and put in an MRI, you will see there is diffusion happening even there. But in tissue, due to a restricted environment, there is cells and other things in the tissue, which restricts this diffusion process. So if we have restricted diffusion, the diffusion rate will be less, the decay rate. So then if we measure that decay rate, we can tell whether the environment has more restricted diffusion, for example. So the diffusion imaging can tell us about the microstructure of the tissue. And in brain, this is used to look at fibers that are oriented, and we look at directionality. But in body, in the rest of the body, except like kidneys, the diffusion is happening isotropically. So it's not directionally different. It's happening similarly in each direction. And we would like to just measure whether it's restricted or not restricted. And also, diffusion imaging can tell us about some microcapillary perfusion, which is happening like diffusion. It's called pseudo-diffusion, but it's actually microcapillaries, like the tiny little vessels, which are perfusing. And that perfusion process can be also measured with diffusion weighted imaging. And those are the, for example, during inflammation or during fibrosis, these microstructural perfusion things, properties change, and we would like to measure them with diffusion imaging. So in the classical diffusion imaging, you acquire images at different B values, diffusion with different gradients, and you basically fit a model, which is actually very simple, just a simple exponential decay model, and measure this decay rate, which is correlated to the diffusivity. Whether the environment is more free, you have higher diffusivity. If it's more restricted, you have lower diffusivity. And as I said, there is this microcapillary perfusion effect, which you can also measure if you acquire images at very low B values. And this is happening super fast. And you need to, this is a big, and to measure this fast and slow diffusion, you need to actually model this process with a, not just one exponential, but two exponentials. And there is a fraction, which is telling what fraction coming from this exponential and the other, D star and D. So you actually measure 4 parameters here, S0, the decay rate, which is corresponding to just slow diffusion related to tissue cellularity, and the D star, which is this fast diffusion due to microcapillary perfusion. And the problem with this is that diffusion is just an inherent contrast, so you don't inject anything. So it's just happening because the water molecules diffuse in body, and therefore the signal levels you measure with MRI are very low. So you have very low SNR, and if you have limited number of observations, you will have to use some sort of prior knowledge to be able to estimate these 4 parameters from double exponential decay signal, sum of 2 exponentials basically. And especially in abdomen, in brain, we have better coils are closer to the brain, but in abdomen, we have even more issues with low SNR. And therefore, we need to be able to generate these parameters with robustness and repeatability. So we would like to solve these ill-posed problem using some sort of regularizer or some sort of learning process. And if you would like to increase the signal to noise ratio, get more signal from MRI, we have to do repeated measurements, and that costs time. And in clinic, nobody wants to increase the acquisition time when the child is lying in the scanner. So we would like to still be able to reconstruct these parameters accurately without doing multiple repetitions and multiple acquisitions, average them to increase signal and signal to noise ratio, SNR. So we have been working on this field for quite a long time, and we have done many approaches, but this is one of the recent approaches using deep learning model to estimate these parameters given the inputs. So the goal is, as I said, can we learn from the network, and can we actually use a 2D network which will denoise the data and do a regularization to be able to more accurately estimate these parameters given the input data with a convolutional neural network. And as I said, to estimate the parameters of this bioexponential model is an ill-posed problem. We acquire, for example, images at different B values, at 7 different B values, and we get some repetitions at each B value. And we would like to be able to estimate parameters with robustness and repeatability. And there is no ground truth parameters. So we don't really know, there is no training data unless we simulate the data, which usually most people do, and we also do it. But for real patient data, there is no ground truth parameters. So in literature, people use methods like spatially constrained model fitting using some sort of graphical models, Markov random field kind of approaches, which we worked on these approaches to regularize the parameter estimation. Instead of doing estimating parameters from each voxel, we basically include some spatial correlations. And there are some Bayesian methods to incorporate priors of the distributions of each parameter. And there has been some one-dimensional neural network approaches, given the signal from a single voxel can be estimated parameters using some fully connected or convolutional neural networks. And in our approach, we wanted to take advantage of also, instead of 1D, we use 2D because we want to take advantage of the spatial regularization effect of the CNNs. So given these images acquired at multiple B values, we use a neural network to estimate parameters. But because we don't have any ground truth, we cannot do supervised learning. So self-supervised learning is a good approach here because we have a physics-based model, and we can use the physics-based model, and we can try to minimize the measure the error, the mean square error between measurements and the model while estimating the parameters. And this can be trained over a training set without any ground truth. And then we can apply it for a new test data and estimate parameters. And we realized, compared to voxel-wise approach with a neural network, the 2D networks had some regularization effects, and they were more the repeatability. In the repeatability test, when we do test retest over the same patient with different number of repetitions, we observed some slightly decreasing coefficient of variation in most parameters compared to classical IVAM, which just fits a nonlinear model by exponential model to each voxel. Deep IVM is a voxel-wise approach, and our proposed approach is a 2D network, self-supervised approach. We also looked at how we can cope with increasing noise or decreasing SNR levels in these different networks. And we realized, again, the 2D network has slightly better performance when the noise levels are increased for all parameters, D star, and F. And in conclusion, I think there is a lot more that can be done for estimating parameters for these kind of models from very noisy data. And there is no ground truth unless you simulate. And it's harder to simulate for 2D models, which actually we are developing some approaches, some generator models and some other simulation approaches for that right now. And it's advantageous to increase the robustness of estimating these parameters even in very low SNR conditions where we have data acquired in clinical scenarios with very fast acquisition schemes, like without any repetition. So that's the goal, or the goal is to estimate these parameters without increasing the scan time. And I'd like to thank you for your attention and just acknowledge some of the funding resources that made this research possible. And we have open positions in our lab. If anybody wants to apply for a postdoctoral position, please email us.
Mm-hmm.
Thank you.
Thank you, Sıla.
Thank you.
So maybe we can get a couple of sort of, yeah, Burak hocam.
May I jump in again? Thanks for the presentation again. We've been working on brain imaging for some time actually, and most recently we are concentrated on connectome analysis. So where we are using fMRI and dMRI for structural and functional. Well, one of the bottlenecks or the main problems that bugs me a lot is that in both of these fMRI and dMRI are pretty indirect ways of observing function and structure, because fMRI is just a bold signal, indirectly related to function, and dMRI is like a very macro scale view of the structure, because you are not actually imaging the neurons or synapses or anything. You are just imaging the main diffusion direction, and mainly using the diffusion tensor imaging, actually. Nothing more than that, not even the higher order things. But actually, there is something going on at the microstructural level. And people have been using that fractional anisotropy a lot, actually, to refer to the microstructure, but fractional anisotropy is so coarse. I mean, it actually doesn't tell anything about the structure, not much at least. So I wonder, I mean, there are those compartment models about microstructure imaging, like NODI and things like that. And as far as I could remember, I don't recall seeing any deep learning approach or an optimization approach actually applied to these compartment models. Is it, is it viable?
There are many right now. It's super popular. And if you look at maybe the last 1 or 2 years, denoising, because, okay, so for diffusion weighted MRI, you are completely right. We are doing some measurements at microstructure level, but our pixels are like 1 millimeter cube isotropic, where exactly. We're trying to measure something at very, very slow small scale, right? So, and there are many like new things and this field is super crowded, by the way, and there's like, I would say the world's really smart people are tackling this problem. And as you said, there is human connectome scanner, which has spatial hardware that could generate better gradients, better, more accurate directional diffusivity measurements in brain, and also higher maybe Tesla's like field strength, so that we can get more accurate, more higher SNR basically, because SNR is the biggest problem in diffusion imaging. And there is a lot of learning approaches, I think, in this field, and especially for denoising. There is also like motion compensation approaches in this field with both learning approaches and classical approaches. And I think there is a great opportunity for learning because, as you said, we are dealing with very complex models like NODI, or even more complex models like our lab in computational radiology lab that I worked in developed. And those models have many parameters, and you are trying to measure it from very small number of measurements. So it's very ill-posed. And so you should really use learning priors and to be able to estimate those markers. So for example, we work on, one of my colleagues work on traumatic brain injury, looking at these microstructure changes, even in like very small hits of the head, right? And they try to see some very mild changes in these markers, which you should be very accurate in measurements. And they use it, even mice, which is even tiny little brain. So I think there is a lot of opportunity for learning approaches, and there are so many new things happening, especially, as I said, like denoisers, reconstruction, image reconstruction, and quantitative parameter estimation.
So it's still an active and an open problem, actually, for the time being, actually, microstructure. One last question, I could, with your permission. Is there, I'm skeptical, well, not skeptical, but let's say concerned, okay, about the diffusion imaging, although I work a lot with diffusion imaging, about the spatial resolution and the source of the signal, okay? Because, I mean, assume that you indefinitely increase the spatial resolution in the diffusion. Then the voxels are so small that the voxels are actually fits into a synapse. Well, if a voxel fits into a synapse, then actually you cannot see the anisotropic nature of the diffusion because the voxel is actually in the synapse anyway. So actually there seems to be a lower limit in the spatial resolution in diffusion imaging. It has, I mean, the voxel should be large enough, and the diffusion time that you let the water molecules to diffuse freely, actually in the restricted media, should be long enough so that you see the anisotropic diffusion. Right? So it's not like only a matter of technology or the technology in the MR imaging, but there seems to be like a fundamental limit in the resolution that you can get, in the spatial resolution, I mean, that you can get with diffusion MRI with respect to, you know, inferring something about the microstructure.
You are absolutely right, but I don't know, like, if our current like limit is that, or it's, I think, as you said, as you pointed out, our current limit is basically mostly if we go very high spatial resolution, you get very small number of protons, water molecules in there, and that give rise to this signal, right? And that
SNR is so low.
So low, like so
low, yeah.
So low. It's impossible to get any signal from that. And there are so many approaches, like, I don't know, super resolution approaches and that tackle. And on the top of that, there are imperfections, like gradient imperfections, B0 inhomogeneity, B1 inhomogeneity, that eddy currents, like so many things happening that you need to model those as well to be even more accurate at very low, high resolution levels. But the field is moving towards a higher and higher resolution, and but I guess there is even more steps that we need, both hardware and software, to be able to get there. But those are points.
We hit a ball. We hit a wall, actually, an obstacle, even before actually getting to the fundamental limit. I mean, so it's still, there is a lot more to do in the diffusion imaging. That's the thing I think you're saying.
Feel free to reach us for collaborations, because we have experts, and I have collaborators, like, for example, Onur Afacan worked closely with an MR physicist. He works on developing these very cutting edge, like super high resolution imaging, like image acquisition, pulse sequence, and artifact correction methods. And we work on a lot of artifact correction stuff as well. For example, distortion is one of the artifacts in diffusion imaging. And I think machine learning can be great for even tackling that, because that generates the susceptibility artifacts in images in brain. For example, there is air tissue interface in sinuses that creates this frequency shifts, and that needs to be measured, and distortion map needs to be created and corrected. So there's a lot of opportunities.
Okay. Thanks again for the presentation.
Yes, maybe we can take a quick short question. Okay, if not, let's thank our speaker. Thank you, Sıla.
Thank you.
It was very insightful talk.
I hope it wasn't too boring for everyone.
Oh, no.
Right.
Thanks.
Oldu. Görüşmek üzere bir sonraki konuşmamızda.